Upper eyelid retraction surgery? How specific is the surgery, and what are the risks of blindness or any other risks? And is it possible that only the part of the eyelid that is lateral to the pupil be brought down, or will the whole lid be lowered?
Thank you for your question. You've submitted a question without a photo, so it seems like you're just trying to get some general ideas about your concern, which is upper eyelid retraction surgery. You're asking how specific it is or how precise and probably predictable it is. You're asking what are the risks of blindness, and is it possible to just do part of the eyelid outer or the lateral part next to the pupil, or does the whole eyelid have to be brought down? Well, certainly I can give you some general understanding of eyelid retraction and what my thought process is when I meet a patient and evaluate them for eyelid retraction and discuss the options for surgery. A little bit of background: I'm a board-certified cosmetic surgeon and fellowship-trained oculofacial plastic and reconstructive surgeon. Eyelid malposition, whether it's eyelid ptosis and eyelid retraction, is a significant part of my practice as a cosmetic oculofacial plastic surgeon in practice over 20 years. So I'll again go down the path of what is the thought process and certainly go over some of the issues about risk. So to begin with, first question I have to ask would be, what is the nature of the retraction? When it comes to eyelid retraction, generally it is associated with something called thyroid eye disease or Graves' disease, or another term is thyroid-related immune orbitopathy. So when that is the cause, you also want to know about the stability of the appearance. Is the appearance stable, or are you still in, there are two phases. It's called the inflammatory and fibrotic stage. You want to minimize the chances of operating during the inflammatory stage because that's an active changing time where the eyelid position can vary, or the fibrotic stage, which is where it's more stable. Assuming that if that's the situation, and then the other situation that does come up is congenital eyelid retraction, which means you're born with it. So now when it comes to eyelid retraction surgery, basically there's the first line type of procedure is called Muellerectomy, where you are actually removing a muscle or releasing a muscle behind the eyelid called Mueller's muscle. And that allows the eyelid to typically descend about 1 to 2 millimeters. Often what I tell my patients is, given that once the eyelid that procedure is performed, I actually want to see the effect. And usually these procedures, I do it under local anesthesia with light sedation. That means the patient is awake during the critical point of when I'm trying to establish the right height and contour. And so we'll actually sit the patient up and see how their eyelid level looks. It's comparable to what we do with ptosis surgery. When it comes to eyelid position, a millimeter makes a difference. So in terms of the other options, there's also a procedure called levator muscle recession, and depending on how much the muscle has to be recessed, they can also require some type of grafting procedure where you actually put what's called a spacer graft, such as what's called temporalis fascia, between the levator muscle and the tarsus, the backbone of the eyelid. When I have these discussions with patients, I say we have to be ready for a plan A, B, or C, depending on what I see during surgery. I know what's more likely to be the case, but I always want to have an additional option. So to begin with, in terms of the customization of the procedure, I would say that it is still important to understand that, yes, it is possible to customize, and if you're describing a situation where you just want the part that's on the outer part, that term probably is consistent, or that situation is consistent with a term we call lateral flare. And very often that is associated with thyroid eye disease. So to answer the question, can you do just the part outside of the pupil or on the outer aspect or the lateral part? The answer is yes, you can. You can certainly customize this procedure. It just depends on how your eye looks intraoperatively. And this is a discussion that you should have with your prospective surgeon. As far as the risks of blindness and other issues, I mean, I always explain to patients that for any surgery, the first level of risk is bleeding and infection. The chance of blindness is highly unlikely. And what would be, you have to also think, what would be the cause of the blindness? You know, there are many potential risks that have more to do with issues with the vision that can be compromised, such as eye exposure or corneal abrasion, that are more likely than frank blindness. So I would say that in the blepharoplasty associated or cosmetic eyelid surgery associated risk of blindness, a number that gets thrown around is something like 0.025%. It's very, very rare, and it is highly unlikely. But it is still something to at least understand, and that's always in the discussion. And of course, it's part of an informed consent. What we try to do to mitigate these risks is to, of course, do a proper preoperative evaluation from both a medical and ophthalmic point of view. Medically, we want to make sure the risks of excess bleeding or potential of infection are minimized. And from an ophthalmic point of view, we want to make sure that the integrity of the eye is optimal so that the patient can tolerate the surgery. So that being said, I think that you need to actually have a one-on-one consultation with a doctor to understand specifically what your situation is. And once you're comfortable with that doctor, understand moving in that the biggest concern that I would say is, for me, is about the aesthetic and functional outcome. When you are changing the position of the eyelid, you can overcorrect, you can have an overcorrection or an undercorrection, which means the greatest concern that I would have is, in addition to those other risks, is about the need for revisional surgery. And that possibility can never be eliminated to zero. Every surgeon has to do a revision for their own work, sooner or later. A very famous colleague of mine said that if a doctor claims never to do revisions, they're either lying or not doing surgery. And I think that's very illustrative of understanding the art of surgery. We're dealing with a human being, we're dealing with soft tissue, and we try to maximize the predictability through exceptional high-level quality surgery, but we're dealing with just the elasticity of the human body and the variability of healing. So understanding that, you have to be prepared, and the doctor can give you a guideline of how often that doctor does revision surgery. And once you're comfortable, move forward with the operation. So I hope that was helpful. I wish you the best of luck, and thank you for your question.